Hello, everyone. Good afternoon. Welcome to our event, Racism and Discrimination in the Healthcare System, with our special guest speaker, Dr. Nche Zama, MD, PhD, cardiovascular and thoracic surgeon. The event is a collaboration between ARCHER, American Romanian Coalition for Human and Equal Rights, and the Arizona American Romanian Cultural Collaborative, represented today by Marie-Louise Paulescu, and I'm Mihaela Campion representing ARCHER. Welcome everyone. Thank you for being here today, and thank you for accepting our invitation, Dr. Zama.
My pleasure.
We are talking today about racism and discrimination in the healthcare system. If I would say this is an important topic, I think I minimize it. It's a topic of a large magnitude that hasn't been spoken enough, in my opinion. And that's the reason we are organizing this today, to bring awareness and expertise in how to become more cognizant of how racism and discrimination shows up in the healthcare system, and also how we can contribute to eradicate it as much as possible. So Marie-Louise, would you like to start this important conversation today?
Absolutely, and thank you, Dr. Zama, for accepting our invitation and for giving us your time. I'm going to ask a question that is very broad, and Mihaela made it sound as if it's obvious why this is an important topic, and it is for many people, but for those for which it's not that obvious, why should we be talking? Why should we be paying attention to racism and discrimination in the healthcare system? Why are you invested in this, in the issues that plague this whole environment?
So thank you very much for inviting me to participate with you in this forum. I have been in the healthcare industry for a few decades now, and I enjoy what I do very much in the capacity of a cardiothoracic surgeon. And I enjoy providing the services that I provide to my patients, just like everybody else who's in the healthcare industry. It's a very important pillar in all our lives. And healthcare undergirds everything we do in our lives. It undergirds education, it undergirds the economy, as we found out with COVID, and the problems that have been associated from the economic standpoint with having to deal with this global scourge. And also, healthcare is one of those pillars in our lives, one of those aspects that triggers a lot of emotional response, this emotionality involved. When you get sick, everybody around you gets sick. It's been said that when a person is healthy, they have many wishes, but when you get sick, you only have one. You want to get well. And so anybody who's a part of that industry appreciates the fact that it is a different industry than many of the other industries, whether it's transportation, whether it's entertainment or whatnot. And also, why is it important? Because it's a part and parcel, obviously, of our lives. If you have no health, life really doesn't mean much. And if your health is not good, and then the next bad step usually is something we don't talk about, possibly death. And our motivation in the world is to enjoy life, live well, enjoy our families, and ultimately, when the final common denominator, death, comes, at least we've lived a life. And so, but when you get sick, there's always the tendency to think that maybe that life would be foreshortened. It's a powerful industry if we talk about it in the context of America, because the healthcare industry is gigantic. There's no other industry in America that comes close in terms of dollars and cents. It is worth $4 trillion, and it accounts for about 20% of our GDP. So when you talk about discrimination in the educational system, and you look at the numerical numbers, and you look at the figures in terms of dollars and cents, you think about discrimination in the housing industry, discrimination in the entertainment industry. Then you begin to see how important this is. I'm not minimizing the importance of addressing these issues in some of those other silos. And I'll see economically, it has significant import. And so it has its tentacles in practically every household and every infrastructure in America. And so, but when we come to healthcare and we see it's so important, and then we realize the problems that we're facing now. Now, if we talk about housing industry, that has evolved to a point where even myself, I mean, if I was here, if we were here talking about 40, 50 years ago, I would be limited as to where I could live in America, even as a doctor. But that has evolved, we have to say, significantly where I can go wherever my dollar would take me. Healthcare is sort of closed in, and most public is not aware of what goes on in healthcare. Their only encounter with healthcare oftentimes is when they come in for a procedure, but you want to make that a short visit because this is not what you want to stay. But the dynamics and the mechanics of how it works within the industry and the events that occur within the industry and affect some of those players adversely, and not issues that are cognizant with the rest of the population. So I think that's what makes it very important, because if it's not recognized, it can be addressed. And if it's not addressed, then it ultimately significantly impacts all of us because of just the magnitude of the industry and the importance in which it plays in our lives.
Sure. But when we're thinking, so you made a really thorough point about the importance of the industry in terms of economics and so on and so forth. But so let's actually focus on race and discrimination. So what are the number one issues that you see in healthcare when it comes to race and discrimination? Or what are some of the issues?
So that's a very important question. And healthcare, I always look at it as a microcosm of the larger society. And so many of the discriminatory and racist policies that affect human life in our daily lives also amplified in the healthcare environment. And I'll give you a little historical perspective in terms of racism in healthcare. And so, and we can go back over 400 years in America with stick slavery, for example. Slaves were not considered humans. They may have been considered 75% human. And that had to be a psychological justification in order to propagate the whole commerce of slavery. Because if they're not pure human, so I don't have to worry about making slaves of them. And so if you talk about the type of healthcare that slaves received in those days, I always give an example of a gentleman that most men and all women would be familiar with, Dr. James Marion Sims, who was an obstetrician gynecologist in the South, who is the gentleman who about 1845 invented what we now know as the speculum, an instrument that is used to perform gynecological examinations in women. And a lot of his studies and experiments were performed with using enslaved women, Black women. And at that time, it was his impression that Black people did not feel pain. And he engaged himself in performing procedures such as repairing vesico-vaginal fistulas. These are abnormal connections between the bladder and the vagina that can occur in women when they undergo a traumatic injury during childbirth, and which can lead to soiling and a lack of control of the bladder and the bowel. And so he would repair these without anesthesia. And, you can imagine the suffering women went through. There was no consent in those days. It wasn't important. He even got to a point where, and he didn't do this with the white women. The white women would get some form of anesthesia. In the mid-1800s, we already had some idea about keeping people comfortable during a surgical procedure, but the Black women didn't get that. And also, his impression along the lines of the care that he provided was that the Black children were not as intelligent, or the Black people were not as intelligent. And so he was wants to perform experiments on children, on Black children, where he was working on a theory that the intelligence of Blacks is less because their skulls tend to grow a little too fast and encase their brains and prevent their brains from growing. And so he would actually use shoemaker's tools to chisel and open the skulls of these kids without any anesthesia. These experiments that he wouldn't think about performing in the white population. But all these ideas were built on pre-existing notions of race and inferiority. And so in the healthcare industry at that time, they were very prevalent. And then moving forward, even when Blacks started to become trained to be doctors, the first Black doctor in America, Dr. Smith, actually trained doctor, was actually from New York City. He finished top of his class in New York City. He applied to Columbia University and medical school up in New York, but he couldn't get in because of his race. And he had to go to Scotland, where he graduated valedictorian, top of his class. So it's got to be some type of discrepancy. So he comes back to the US. And so we're talking about not just the care they received, the racism during that era, but also for providers. When he got back to New York, he was not allowed to practice medicine because of his color. And he had to relegate himself to practicing at some type of orphanage home or facility like that. Even the American Medical Association would not admit him to give him membership, despite his performance in medical school, the fact that he trained in Europe and trained in Paris and whatnot. And if you think that's worse, another example that a lot of people know about is Daniel Hale Williams, who in 1893, I sit here today as a cardiothoracic surgeon, but if you ask a lot of people who performed the first heart operation in America, the last person they would think about was African American. But this is a guy who in 1893 opened the first hospital, which is Providence Hospital in Chicago, and a nursing school. And it was the first interracial hospital and a nursing school. And he was not allowed to practice. He was a surgeon in the white institutions. And a gentleman called James Cornish presented one day with a stab wound to his heart. And he was able to open this gentleman's chest and fix this injury. That was the first heart surgery. Now, he also was barred from the American Medical Association. So when we talk about racism, it's not just those who are the recipients of the care, it's also the providers. And the history didn't even stop there. Charles Drew, yesterday I gave a lecture on blood transfusion, and I may not have mentioned his name to the group that I was talking to, but this is a man who had a pivotal role to play in developing blood banking techniques that have saved lives up to this day, and especially during the Second World War, because prior to that, there was not a very good infrastructure to provide life-saving blood to people who had suffered tremendous trauma. He protested racial discrimination because of, in the healthcare community then, if you were sick and you needed blood and we had the same blood type, it would not be recommended that you receive my blood because of my race in a hospital. So sometimes you would have white folks who were willing to donate blood to save a Black person's life, and because of discriminatory policies within the healthcare system in general, that would not be possible. And I give you another really powerful example of a gentleman too. Vivian Thomas. If you've watched, there was a special in television about 20 years ago, maybe 16 years ago on him, who was hired at Vanderbilt University Hospital in Tennessee in 1930 by a gentleman called Alfred Blaylock. He was the chief of surgery, and hired him just as a janitor. And while he was there, he was given an assignment to take care of the animals in the laboratory. This guy had a high school education, but he was such a brilliant young man and he was such a fast learner that within a few weeks, he was already performing operative interventions on animals, just like his boss was. And his boss was quite impressed with the work he was doing. A lot of experiments came out of there. For example, the understanding of shock and the treatment thereof. That Dr. Blaylock got hired by Johns Hopkins University in Baltimore, and he took him with him to this new position in Baltimore. And when they arrived, there was a cardiologist in Baltimore at that time. It was around 1940, who approached Dr. Blaylock and said, I have so many children who are dying from blue baby syndrome. These kids are born, they look blue because they had congenital heart problems. And at that time, nobody knew what to do with them. But it was extremely frustrating for this woman. Her name was Helen Taussig. And so she asked if there was a technique that he could develop to intervene. Well, the work that he'd been doing in the laboratory with animals was work that was similar to what she needed for the humans. And who did most of that work was actually Vivian Thomas. And Vivian Thomas is the one who perfected the technique. And ultimately, when it went live, Vivian Thomas, being a Black man in Baltimore in 1944, did not have the opportunity to be in the forefront with the rest of the team, but he had to stand behind Alfred Blaylock in the operating room and instruct him how to go about doing the operation. And so a new operation was developed by both gentlemen called the Blaylock-Taussig shunt that saved lives of thousands of kids. And it would not be till decades later that his contribution would be included. And I have to say how powerful this is, because I trained at Harvard Children's Hospital, Boston Children's Hospital, and not once during that time did I hear much about Vivian Thomas. And even the textbooks that we use didn't include him in it. But as an attestation to the fact that we've come a long way, if you open a textbook of cardiothoracic surgery now, you will see his name there. And he was acknowledged and got an honorary doctorate from Johns Hopkins University. So it's not just in the delivery of care and the patients who are the recipients of our care. And this is a problem that's continued over the years. So I mentioned Black folks in general, but if you look at the history of Native Americans, you find the same. If you look at the history of Hispanic Americans, you find the same. If you look at even the history of immigrants, the Irish, when they first came to the United States, you see the discriminatory policies of the early arrivals toward them. But by and large, if you look at the entire spectrum of history, I believe that the African Americans and maybe the Native Americans have suffered the most. And the consequences of discriminatory practices within the context of society spilled over into healthcare. So to address healthcare issues, you really have to look at society in general.
I remember in one of your articles, you openly and honestly spoke about your own experience with discrimination while wanting to go to medical school and also after you finish medical school. We also know that only 5% of American doctors are Black today, which is a very insignificant number considering the potential. And we also know that leadership in the American healthcare industry is almost exclusively, you said in one of your articles, white. And not only white, but predominantly white male.
Yes, yes. So,
What
yeah.
do you say about that?
Yeah, well, I give it from my own perspective and my own experience. When I was about 9 years old, my mother, and just for clarity, I was born in Cameroon, Africa, and I came to the United States when I was about 14 years old for college. I'd skipped a few grades. That's a whole nother story. But my mom was giving birth, and then she died during childbirth, or after childbirth actually, and she hemorrhaged because they didn't have a doctor. And I always remember the nurse was crying and saying there is no doctor, and then she died. And as I left on the trek back to the village, I decided that whatever the doctor was seemed to me like somebody who saves lives. So I want to be a doctor when I grow up. And so I had that determination and fervor at a very early age. So when I graduated at a younger age than my cohorts in high school, I knew I was going to go to college and on to medical school. So in college, everybody who intends to attend medical school has a pre-med advisor. So I had a pre-med advisor. And it so happened that my classmate, a couple of my classmates were roommates and dorm mates that had the same pre-med advisor. And so when I approached him, and mind that I had to skip a lot of the freshman courses because I went through an extremely rigorous secondary school curriculum where I'd taken calculus and advanced physics. And so I challenged those exams, a few of them, and did well. So I wasn't a bad student. But when I talked to him about my career goals to be a doctor, without missing a beat, he told me that maybe you should consider something like hygiene, laboratory medicine, and he didn't really say because you're Black, obviously, and a lot of racism is not in your face, but it is just implied. And I wondered why he was, scaring me away from what I really wanted to do. And so I thanked him and left, never went back. So I had a conversation with my colleagues afterwards, and he says, does he have a tendency? Oh no, I sat with him, and my roommate said, he said, oh, this is good. These are the courses you need to take, and these are some of the medical schools you need to be thinking about. And when time comes, I'll get you a recommendation. So, and interestingly, I was tutoring my classmate chemistry and math. So I really couldn't have been a bad student. But that was so discouraging that I decided, and for a child, I was very young, probably about 15 years old at that time, I decided that it would not be possible for me. So I needed an option. And that's why I thought maybe I could be a researcher and get a PhD, and which I ultimately went on and got an MD too. So starting at that point in college, his attitude was racist. There's no other definition for it. And then I got into medical school. And my experience in medical school too was, people always approached you and thought you were there, you needed remedial work. There was always the stereotypes. And if you got a very good score, they paused a little bit and looked at you like, how did this happen? And while in medical school, I realized some of the white students had the attending, so the professors were more attentive in discussing options with them after graduation. So if you wanted to be a pediatrician, they may tell you, well, why don't you do some research and publish in some journals? That way you can, it would increase your chances of matriculating in one of the top programs in the country. Or why don't you consider pediatric endocrinology down the line, a subspecialty? Some of that type of engaging, mentoring and advice. You talk to a lot of the Black students or African-American students, they didn't have it. And so I made the decision to be a surgeon. To become a cardiothoracic surgeon, you have to be a general surgeon first, so finish general surgery and then do a few years of cardiothoracic surgery. I never knew anybody that I could talk to. And oftentimes when I go through the rotations with my colleagues in medical school, the attendings will pull aside my colleagues and talk to them about their career goals and help to counsel them. There was not such a voluntary effort. And in my articles that you probably read, I related an instance where a lady, chief resident, they have chief residents of very powerful positions in the hospitals and teaching hospitals. They're like the attendings, so they're in the final year of training, and gave me one of the worst recommendations for somebody who's thinking about going to surgery at that time, to say that I was not, my performance was subpar, and I probably did not have the cognitive abilities or the technical know-how to become a surgeon. Now, where are you going to go after that? You essentially kills it. And she said that on the basis of me not being as verbal or vocal during my rotation. You know, you got a scared third-year medical student. But I had all my colleagues would often speak really loud, but not making much sense. And I was always the very quiet kind. If you asked the questions, I would answer. I didn't just volunteer. And I didn't carry a bunch of books with me like many of the other folks did to impress me. So it was easier for her to draw the conclusion. And I must say this because there was about 10 of us in the group, and everybody got an excellent evaluation. I had the worst. And not only that, I was a tutor, is how I made my money through medical school and college. And I was tutoring a few of my cohorts in the group. And it doesn't end there either. So you go to residency, and I had, often I was the only Black resident in the surgery program at the Cleveland Clinic at that time. And I was actually the #1 pick that year. I'm not sure they picked it based upon my grades or whatever. And, but then the vast majority of my attendings were outstanding. There was a gentleman who happened to be the director of the program who had a determinant factor in whether or not you get promoted. And so who didn't really like me very much. He would always assume that maybe I was doing drugs or something. And he talked about my sexuality. I was practically asexual during that time. I was a married man with 2 children. I got married young. And he would oftentimes invite the residents right in front of me to his house and pass out the invitations to them, and I wouldn't have it. I don't know how you can describe that, but if you don't have the resilience and tenacity, you may not feel as motivated to either pursue a specialty that you could have or motivate somebody else to get it, to pursue a career in medicine. And this is what I talked about in my writing, how you pretty much suffer in silence because the system is so systemically structured to be that way. And I went through fellowship at Harvard, and every day I would be asked, how'd you get here? And I said, I made some comedy of it in one of my writings, and I said, I'm sure they weren't talking about the mode of transportation. How did I get to Boston at Harvard? Even though I got there on merit. And it was on a daily basis. There was always somebody who would pause and look at you like you just flew in from Pluto. But there was nobody to really engage you. And so oftentimes you have to rummage around and look for opportunities, and even looking for a job when you graduate. Some of the guys who were not as good as I am got offers immediately from the school for post-graduation. But the guy like myself would have to kind of hustle on their own, and then in professional life too. It didn't even end there. I remember my first day at a new job in the locker room. I talked to the surgeons. And I was the only Black person, and they all kind of stared at you, and nobody puts their cards on the table. I mean, they didn't. And so I went on and did my operation, and it would take a few weeks until people started to realize that, wow, you really can cut. Then all of a sudden, they slowly start to warm up to you. But if I have a certain level of inner tenacity to be able to withstand that, there are not a lot of people who can undergo such experiences and not be destroyed by it. You understand? And so I write about it and I speak about it because it does exist. And so it's my own experience, but I also witness others that are not necessarily African American. I had a friend who got into cardiothoracic surgery, a woman, and she happens to be white, Caucasian. And they gave her the roughest time you can ever imagine, because it is a male clique society, and she happened to have intruded in it. So whatever she did could not be right. And she was scanned with a microscope at all times. Whatever she did, her outcomes. They spent a little bit more time with her than they could have with the ones that were not performing well, with poor outcomes and poor quality work. But because of her gender. So it's not only racial discrimination, it's gender discrimination. You know?
So if we're talking, so as a reminder, you said at the beginning, we're talking about discrimination both against patients and towards doctors, nurses, hospital staff. What are some solutions? What are the things that can be done? Maybe things are already starting to or moving slowly in the right direction, but what should happen for this to be better? Because it's not fair, because you said, there are few people who would go through what you did without being destroyed. But I still think that even though, you're still standing and you're still doing your job, I still think that there are wounds in there, right? So how can we make sure that no more wounds like this are created?
So I must say that obviously society has evolved in the past 400 years. And some of the malicious treatments that the slaves in 1813 and 1845 experienced are not as prevalent now. But we still have a long way to go. And so to address the issue of racism and discrimination in healthcare, we have to look at the various pillars that constitute it. Now, you can't really solve human attitudes in healthcare without addressing them in the general context of society. So I think there should be some emphasis in equitable educational experiences. That's where it's good to start. So children in elementary school get exposed to positive role models and get to learn about opportunities that prior to that were generally subtly relegated to the majority population. And I think we need to start really heavy. To solve this, you can't fix broken adults, but I think we can start a new trajectory with the elementary school system, with children across the board in America. I think too that we have a golden opportunity, window of opportunity now, because global society is at a crossroads. Many of these things that I talk about and that we talk about in the past were hidden from the public. It'd be hard to get a Tuskegee experiment now like they did in 1932, where they lied to people and gave them syphilis, or those that had syphilis and they told them they were getting treatment where they were not. You know what I mean? There's a little bit, medicine has evolved from that. So I don't want to just paint a negative picture. And also society, if we look at what happened last May with George Floyd, and we saw the global response to that. Well, that's not the first case of violence perpetrated toward anybody, whether it's Black or woman or some poor person of a different race. But the global reaction was a little different last year than it previously had then, and which tells me that truly we are at a point, at a crossroads in life, and we need to capitalize on that. So I think focus on education, one, and start addressing it, because it'll be a long period of a couple of decades before we start reaping the benefits of that. Secondarily, when you focus on education, you will be able to increase the number of minorities in healthcare. The studies have shown that Black patients have better outcomes when they're taken care of by Black doctors. Now, I'm not saying that Black patients should have Black doctors and white patients should have Black patients. And when that study was shared with the public, some people probably didn't understand what underpins that. And truly what underpins that is that a Black doctor understands the Black patient, understands where they come from, and care has to be holistic to be effective. And so if a white doctor, not all white doctors are racist or discriminatory in their behaviors, but if it's just one of those that happens to be there and has no connectivity between them and the patient, and we know that a good outcome is not just relegated on pharmacology, pills and scalpels, it's psychological as well. It's how you feel. You know, illness is just a composure. And so they do better with Black doctors, not because the Black doctors are smarter, because they're more attentive to them. And when you're attentive, you may be able to discern certain aspects of disease that somebody who was very peripheral in the approach probably would not have. And then it would not lead to as good an outcome. So I think we need to increase the number of minorities in the healthcare industry. That starts with an educational system. Now, you just can't grab anybody from high school and say, hey, we need to increase it by 30%, so we need more of you. No, medicine is difficult. You need the cognitive acumen to be able to enter medical school. I don't want anybody who just went through a quick apprentice to be doing heart surgery on me. So you have to make them competitive. And to make them competitive, you gotta have an educational system that is meaningful from elementary school, from secondary school, and then they come prepared. One of the problems students have is that they may have an ambition to be a doctor, but there are prerequisites. I mean, I'd love to fly the space shuttle, but there's certain things I have to learn first. I have to go through the process to be able to qualify to fly the space shuttle. And so society has to engage these kids and prepare them so they get to college, they can get the grades that you need to be able to qualify you to apply and enter medical school. And also, healthcare has to be patient-centered. And our healthcare in America is drifting in a direction that makes me quite concerned, because it's drifting in the direction of the bottom line. You know what I mean? You know, how much money are we making? Insurance payments, providers, payers, and sometimes in entire discussions, there's no mention of patient. You know, and so if there's no mention of patient, you can imagine what happens to that poor patient. They don't have to be Black. They can be white, Black, or whatever race it is. My feeling is every patient has to be treated well, treated equally. But if you get to a point where the economics of healthcare matter more than the person for whom, you know, for which reason we're here, that gives us reason for our job, and then those who are economically or socially disadvantaged get to hurt more than those who are not. Because those who are not have choices. The most powerful word in the English language, I always think, is choice and is option. They have options. So that's one of the ways we can use to address it. Because by and large, if African Americans constitute about 25, 35%, and who knows the numbers, you know, of American population, and only 5% of them as physicians are represented in the group of doctors in America, that is a problem. And that's a problem that needs to be addressed. How do you address this? It has to be a concerted effort, a concerted collective effort by all those with power to do it. I mean, the medical organizations like AMA. I was glad last year AMA came out with a statement in support of anti-racism. The Society of Thoracic Surgeons, of which I'm a member, came out with a statement. That should start there. but just making statements is not enough. We should make sure that within our ranks, we facilitate the process for others to join. People want to feel welcome, because if they are feeling welcome and they're welcome, they're more likely to go out in the community and engage other members who are underrepresented to consider the possibility of a career in medicine or career in a subspecialty. And that should be it. And also at the administrative level of the hospital, somebody mentioned that too. It's you know, the whole philosophy of no mission, no money, no mission. We need to have a more diverse administration in healthcare in the US. It's a huge industry, you know, and oftentimes when you talk to Black patients or Hispanic patients, or maybe even some of a patient from Romania who can barely articulate a couple of words in English, they always feel so out of place, so lost in a healthcare environment that is so fast moving, and which is horrible, because you come to healthcare when you're most vulnerable psychologically, and then to encounter a system that you perceive that does not have your best interest at heart and doesn't welcome you is probably one of the most devastating experiences there could be. And if you have leadership that is more sensitive to that, I don't mean a white male cannot be sensitive, but it's a greater chance that a white male in healthcare didn't come from the underclass. And so they were not exposed, they didn't learn about it, they haven't experienced it enough to incorporate it in their DNA, you know, and manifest it in their actions. So a more diverse administrative structure with women and minorities in healthcare would go a long way in improving the experience, the healthcare experience for Blacks and other minorities.
As a professional myself, I'm passionate about mental health, and I would like to ask you a question in relation to that. You mentioned in one of your articles that no one seems to talk about the epidemic of depression among the poor and minorities. You also said that mental health conditions such as these are rooted in racism, discrimination, and marginalization, and need to be recognized as such. Right. I would add that it's not only depression as an epidemic, it's also substance abuse, anxiety, post-traumatic stress disorder that we see in numbers more relevant into minorities or people who have suffered discrimination of any sort. Right, How do you see this epidemic in mental health manifested in medical physiological symptoms? Where do you see that intersection between the two?
So when the mind is sick, everything is sick. And when you talk about mental health issues, people, well, it's sort of taboo, unfortunately, in some cycles. And in medical school, we're all trained to get a complete history. And oftentimes, even when I read the reports by some of the residents, it's not included in them, you know, the medical history. You know, have they had suicidal ideation, have they been depressed? And so it's mental health in some ways, there's some people who just have organic mental problems, but some of those that are associated with existential experiences, whether it's in the community, the economy, unemployment, poor housing, crime, all these things that affect them. And since in this context of discrimination, mental health issues are prevalent in minority communities. You live, and especially in the society where we are, where there's this stark crevasse between the haves and the have-nots, the privileged and the underprivileged. And so, and you see signs of it every day when you exit your door and you walk down the streets and you walk into the hospitals. And that creates a chronic condition over time that in many ways puts you in a true disease state, mental health state. So we see it a lot in minorities. And the thing about it is the only way you can elicit it is to talk about it. And more often than not, we as providers do not, interact with patients to the level where we create a comfort so they can discuss those issues. We also know that if you have mental health problems, I have mental health problems. It's global. I mean, I go through periods of depression, probably less now than I used to, but then you look at somebody who is unemployed, a single mother, 3 children, living in the ghetto, poor water supply system. It's in Detroit. There's lead in the water. You have no job. We've got bills to pay, and this continues ad infinitum. What is that going to do to the body? So we cannot address mental health in isolation. We have to address it in the context of the myriad of experiences on our daily lives within society. And so when we talk about that in healthcare, if you come into the healthcare system with all those living experiences that have affected you adversely, and then you have adverse experiences in healthcare, healthcare should be the sanctuary where I show up and it's sort of a relief from the burden that I carry in society. And oftentimes those people show up and they leave with an even greater burden because the healthcare experience has not been what they expected. So that's what I was talking about, epidemic of health, of mental health issues in society amongst minorities.
Thank you.
Let me make another point there, which is very important, that we can all relate to. There's an opioid, a narcotic, let me just call it narcotic. Everybody says opioids, but narcotic epidemic in the US. Last year, close to 80,000 Americans died from it. In my own state of Pennsylvania, probably about 3,000-4,000. And we don't know the true numbers, you know what I mean? And the deaths may have been attributed to other problems that are really related to narcotics, and that's mental health, the entire spectrum of it. Now, in the 80s, the pictures that we saw in the 80s, for those of you who were around in the 80s, were pictures of inner city boys and girls doing drugs, getting arrested. Crack cocaine became very popular. And so many of them are languishing in jails across the US. Some have died in jails. They were arrested because it was considered a criminal activity and the behavior was labeled criminal. And all of a sudden in 2020, now it's a clinical problem, which needs therapy, which is appropriate. Now, so when you talk about discrimination and racism, back then it wasn't looked that way. But now when kids in the suburbia, physicians, professors, doctors, scholars, middle class, upper class people, it has become a clinical issue that needs to be addressed. And that's the way it should always have been addressed. So if you think about the impact of that, the mental health impacts of that 30 years ago that were propagated over the ensuing decades to this point, you can see the magnitude of mental health problems that are so prevalent in those communities. And then you look at COVID. The mortality for COVID, if anything, it's played out racism and discrimination. The vast majority of people who are dying have been the poor. They've been the Hispanics, they've been the Blacks, they've been many of the inner city folks. And so one of the things I said, you can't look at it in the context of just discrimination. It's a healthcare problem. If you're a bus driver and you live in the Queens and you get up in an apartment complex in the morning and it's March 2020 and you go to drive your bus, 1,000 people enter and exit that bus within an 8-hour period and they carry viruses. What do? You get a dose of COVID virus. You go home and in your building, the congested environment where you live, it's not very good air circulation. You pick up a few viruses in the doorknobs on the way upstairs. So your body's fighting this load now, But the next morning, you got to go again and drive that same bus in an atmosphere that has minimal ventilation in New York City with all the congestion. And what's going to happen? Your viral load is going to be so astronomical that within days you're in an intensive care unit and you're intubated. Now, what's worse? You don't have access to health care, so you have high blood pressure that's not well treated. You have diabetes that's not well treated. You may not even smoke by virtue of the fact that you live in an inner city, you have COPD, because the carbon monoxide and other toxins are everywhere, they're ubiquitous. So you already have major risk factors, and now you have COVID. And predictably, the outcomes are poor. Now, it's not because the Blacks have a certain genetic, look at Africa, they're not dying from it. You understand? So it has nothing to do with the genetics, it has a lot to do with the environment. And so the way racism impacts us is something that oftentimes you have to look at from an analytical perspective, because it's just not in your face. So it's racist housing, the economy, unemployment, and all these things conjoined, impact a personal health. So in one of my articles, I say, unemployment is a public health issue. Poor housing, substandard housing is a public health issue. So it's not just the obvious drug abuse.
Yeah.
And look at the denial amongst people now for vaccines. Now, in November last year, about 30% of Americans said they would not take the vaccine. Now, that's 30% of all common, all races. In the African-American community, probably about 50% of them would not take the vaccine. And the conspiracy theories that are so prevalent in the internet and cyberspace are much more effective within those communities because of historical experiences that have been handed down. The Tuskegee experiment, this forced sterilization of Hispanic and Black women for 40 years, with the US government, at the crux of it. The use of Blacks for experimentation in healthcare. As a scientist, I use certain cells called the Henrietta Lacks cells, research cells, and I didn't know where they come from. Years later, I found out these were taken from a woman in Baltimore, an African-American woman, without her consent. Well, it's great for science. There's not a laboratory on Earth that doesn't have her cells in it, But Black communities, African-American communities hear these stories. And then it's easy for them to be convinced that a vaccine will alter their DNA, and maybe it's a conspiracy by the federal government, because the federal government has always been in conspiracies to hurt them. And if you think this is ancient history, if you just look a couple of years ago in Detroit or in Michigan and see what happened with lead in the water, the authorities knew what was happening, and nobody decided to do something about it. Everybody chose to be, mum about it until it had to surface. It took an aggressive pediatrician and a few other concerned human beings, So with those fears, anxieties, and neuroses that are implicit in their experiences and historically and concurrently, I can understand why a lot of people would be hesitant to accept a therapeutic intervention that can actually save their lives. And that's why a few days ago, I decided to write the article I did in Facebook and try to reach out as often as I can to members of the community.
Very helpful. I would like to open up for questions from the audience, if we have any. I'm going to check that. And meanwhile, Marie-Louise, if you have a last question, feel free. And I will gather the questions from those who are listening to us.
I just wanted to go back to what you were saying earlier. So you said, you talked about the history of discrimination against African Americans and Black people and minority people more generally. You talked about the fact that things are better, but then on the other hand, things are also bad. You were talking about the fact that people think Blacks are more resistant to pain, and we were talking about not doing the interventions without anesthetics. But it was only four years ago, a study found that many white medical students wrongly believe Black people have a higher pain tolerance than white people.
That was at the University of Virginia, yes.
And of all the participants, 73% held at least one false belief about the biological differences between races. And in white, right? White medical students, experts, specialists, right? So what are the pressing issues today? How do we address them? So if you had the power to do so, what would be one thing you'd do?
I am a fundamental believer and optimist in the fundamental goodness of man, of humans, that within every human being, there's good. And but we also know that I had an uncle, and I wrote this in my book, who always, he looked at me one day and he says, within all of us, there are two hyenas. There's a good one and a bad one. And he says, what trajectory you follow in life depends on which one you choose to feed, you know? If you feed the good one, well, then things will work out well for you. If you feed the bad hyena, you may run into problems. And so I believe that with greater transparency and education, as our kids grow, people learn and recognize and be able to discern truth from the past myths that they've inherited. It takes a while to do that. So I've always said, if you see a lot of Black folks, they have had these racist experiences in a way incorporated in their genetic material. So they're very suspicious, very worried, and it takes a lot of convincing. So it's going to take education on their part to accept that there is change. Also, in the white folks, many of them learn these. Racism is a learned behavior. There's no child that's born. We corrupt those kids. We do. And so because it's a learned behavior, it can be unlearned. And so that's the best treatment, I would think, or best way to be able to undo it is the education. Now, it's not easy. I say there's been progress that's been made. Some of it has been policy-wise. If you look at President Johnson in 1965, for example, establishing Medicaid, for example, what did that do? It did something really powerful and positive. What it do is that prior to that, segregation was right, and still was to a certain degree for several years after that, during Martin Luther King's era. But the federal government began to reimburse for care. So hospitals that generally would not admit Black patients began to see the economic value of doing that. And so in a way, healthcare began to become economically, humanistically integrated, but fostered by economics. So that has evolved over time, where now it's rare in America to find an institution that would say, hey, well, you can't come here on the basis of your skin color, you know? Now, but we're not there yet. We need education. I think in my own experiences, things are a lot better. What I experienced during residency, it'll be hard to find now. You may still find pockets of it, because there's recourse. In the 90s, when I was at Cleveland Clinic, when he was yelling at me and says, sit down, and I'm talking to you, are you doing drugs? I mean, these are the type of questions you may not have been asked. Now, I've never even smoked a cigarette, never tasted a drop of alcohol. And I'm not condemning those if somebody chooses to do them. But people who knew me knew that I had. But nobody else in my cohort was facing these types of assumptions, and then threatening me with dismissal. Even when my performance was considered stellar, I graduated with a top award at the Cleveland Clinic. So this was an affirmative action. You understand? So I'm just trying to make a point here. But now there's recourse. In those days, you had to continue to work until the job was done. And sometimes we went 120 hours a week on being on, relative on call. And then there were time limits. 10 years later, 80, 90 hours a week. And they had to stick to that or you lose your accreditation. So there's recourse. So things have changed. Having said that, it's a little bit sad because just a few days ago, I was reading about an African-American doctor at a hospital in Los Angeles who got involved in a medical student group. They have them in teaching groups, and they were encouraged to talk about racism because it's healthcare. Mental health is part of healthcare. You know what I mean? Racism is part of healthcare. And apparently the leadership of the school didn't like it and she was summarily dismissed. Now, she was reinstated with certain qualifications. I'm not sure exactly how it's going to pan out. But it strikes me as interesting because, wow, this is 2020 and we're still experiencing this. But we're not experiencing it to the same magnitude, but it still really bothers me, with all the knowledge and intelligence. So I think the word I would use is importunity. We must keep on keeping on and educating people and start with the children, because many of these bad ideas are imprinted in children at a very young age and impressions about others and race. And then it's hard to undo them later on when they become adults. And then these ideas begin to rule them and mold them and influence their responses and their interactions in the greater public.
Excellent points.
What we're doing right now is really helping out in a tremendous way, because there may be somebody out there who's listening who, hopefully something in what one of us says will trigger, a thought that will lead to a response. Yeah.
That's our hope too.
Yes, exactly. And I think we can talk even another hour probably. It's so vast, the topic, and you are such an incredible, resourceful person. But I would say let's move to questions from those who are listening to us, and let's see what we got there. One question, it's pretty much the same, coming from two Archer members, actually, from Andrea and Donna. They are asking, what's your opinion about a single-payer healthcare system in the US? One is asking, and the other one, Medicare for all. So pretty much the same. What's your opinion on that as a way of accessing the healthcare system?
Yeah. So one of the most common causes of bankruptcy filings in the US is inability to pay medical bills. And that's a serious problem. And it creates significant anxiety within a lot of people. So the question has been, in America, should we have a single payer system? And some people choose to call it socialized medicine, which in a way it would be, as you do in some places in Europe and even our neighbor in Canada. How would that impact the quality of care that we get? There's been no question. If you have a single payer system, would the government then begin to have significant control over healthcare? And people have those concerns. Remember too that whatever payer system we have has to be looked at in the context of our economic structure. We're a capitalist country, we're not a socialist country, So it's a free market. And so that's why some people have better insurance than others. So people talk about, I got good insurance, or I don't have good insurance. I have Medicaid, I have Medicare. So a single payer system, in my opinion, will create problems because there are always going to be people who will opt out of it. And you can't tell them not to have their own system. I think that the problem is not that. I think that we should be able to, and Obamacare, I don't like to call it Obamacare, Affordable Care Act, really was trying to address this inequity. You should, yes, have a payer system like Medicare, but also people need to have the latitude and flexibility to receive more. Now, let me take home message here. I don't have all the answers, but remember, why is this a problem in America, healthcare? Why does it cost $4 trillion? You know what the answer is? It's not because I get paid too much. Well, sometimes I think I do, you know, I'll take it. It's not because your hospital room costs a lot, it's technology utilization. So, but Americans are used to it. If all of a sudden I says, no more cell phones, let's go back to, you know, landlines, it worked fine. And payphones, I don't know if any of you use payphones, they still work, but you've gotten so used to cell phones that you're not gonna part with them. How many people get off Facebook and then come back again, you know? So if you all of a sudden say, the government has to pay for it, who's gonna pay for the technology that we've gotten so used to? So you need a PET scan, you have a breast mass and it was removed and now they're trying to see if it's anywhere in your body. A lot of the PET scans will not come out positive, but in your mind, you'll always say, if I had the PET scan, at least I'll know. PET scan costs you $10,000, $15,000. So there's gonna have to be a different tier for those who can afford it. So the entire concept of having a single payer for everybody in America is going to be very difficult to attain. What we need to be working on is to make sure that the system provides access to those who are not economically competent to be able to enter it to receive the care that they need. We need to work on programs such as Affordable Care Act and modify it and strengthen it and make it better and not try to disassemble it. Because we're a capitalist country, we're a market-driven country. And so, and that's why a lot of the proponents of this always fall back with stumbling words and they don't know how do you go about doing it? It's not easy. And I gave a talk in Greece in 2014 on the American healthcare system, payment system, and how it evolved from the 1800s up to 2014. And I had to do some research to do that, and it's quite interesting. Every president, starting from Lincoln, all the way up to George Bush. And you remember in the 90s when Hillary Clinton decided to take on healthcare, and it failed miserably. It's complex. It's got so many moving parts. It's like that thing kids play with, there's a squeezy, you squeeze it, you can never reduce the size of it, it pops out between your fingers. You know what I mean? That's healthcare. And so the Affordable Care Act was the first time ever that a significant problem within healthcare payment and access was addressed. And instead of us capitalizing on that and seeing what we can do to make modification, to expand it, improve on it, we started to tear it apart. And in doing that, we begin to lose the opportunity. So we've reduced it to a point where we have to rebuild it. You know, you've built a house, now it's reasonable. You know, maybe you need to fortify it a little bit. No, you start chipping away the foundation again. What's going to happen? It collapses, but then you're obligated to build it again. And the very people who are great beneficiaries of it are some of the ones who've been bamboozled, you know, to speak out against it. You understand? I see a lot of my patients wouldn't have been able to see me for heart surgery if they didn't have the insurance from the Affordable Care Act. So I think we should keep it multi-tier, but we can work on improving that access so every American male, female, mother, and child should be able to access the healthcare system. And this forum doesn't allow us the opportunity to discuss that in detail, but I know that we can do it, and we must do it.
Okay. Let's see, we got a few comments here, and thank you. I'd like to read one of them from Krina Tarasi. It is very hard to change people who have no clue they are wrong. Most white people have no clue that they are racist when they are. What can we do with them as healthcare provides and patients now? I think she meant healthcare providers and patients now.
When Mother Teresa was asked years ago, how can we attain world peace? She says, go home and love your family. And I always say, start with your neighbor, start with the patient who is sitting in front of you, who is probably from a marginalized group. And I don't like to get into the whole black and white thing, because we're all the same. We're all Homo sapiens. We're all children of God, if you want to look at it from a spiritual sense. I've been in the human body, I've been in the head, the chest. Oh, I don't see a difference once I'm in there. Now, when I come outside, I may see a little bit more melanin, and some people a little less. But that in itself has nothing to do with the functionality of the body and the soul. So if somebody is in front of you, don't always assume that they may be doing fine, but show them some of the love that you know you would like to receive yourself if you were in their position. That's how we begin to do it. And that's how I have practiced medicine. I can say that I've done tens of thousands of operations, and not one patient I've ever encountered has received less. Now, there have been some experiences, and I wrote about one where just a few years ago, not far from where I am, I'm asked to see a man who's having severe chest pain, is not doing well, just had a heart attack, and he refused to have me as his doctor. This is the first time I've ever been rejected as a surgeon because he wanted a white surgeon. Well, there are not a lot of black heart surgeons on planet Earth. So for a racist, this can be very traumatic if I'm the guy that walks in. And if he already has certain feelings about black people, who's probably done something to a black person before. And now this one is going to wield a scalpel to him. So there's a lot of things that undergo the dynamics. What I did was, racism is learned. You can help somebody unlearn it. You don't have to confront it, but you can, in your own action, let them confront it, because they're the best teacher to themselves. They're the best doctor. They can change it. That experience, and I wound up operating on him because the cardiologist says, we're not letting anybody, it says, if you don't want him, you can leave. He can operate on me. So if you don't want him, you can leave. And then I guess because he was having so much chest pain, what do? You don't want to die, So he acquiesced, not out of love for me, but out of need. And after the operation, I took very care. I came in every morning, and I made him very uncomfortable. I know I would sit in his bed, and I always held his hand. I always touched him physically, and he would cringe. And as the days went by, I noticed he had a little less muscle contraction when I touched him. He was a little bit more relaxed. And when I saw him in clinics, he was joking and carrying on. He was hugging me. I did another guy when I was in Cleveland, and you read my book when it comes out in a few months. When I walked in to see him, he wouldn't even acknowledge me. And he was as recalcitrant as they come. And I talked to him gently. He says, I don't need surgery. I don't need you. I walked away, gave him my number. If you need me, call me. I'm here to serve you. That's my job. And eventually, he did call. I came in, operated on him, and he called my office every day. He was in Sandusky, Ohio, and crying. My secretary says he calls and cries every day, says how much he loves you. And one day he came to see me, and he was in tears. I had to give him some Kleenex. He's a pastor. He'd been racist his whole life. And since the operation, I did a 5-vessel bypass on him, quintuple bypass. He says, I preach about you every day. My view on people has changed. And, so my behavior helped him transform himself. I can't transform you. You have to transform yourself. but it's what I do that provides the catalyst for you to be able to, gives you a prism so you have a different perspective on yourself and the world around you. Because so many racists live in the world that they live in is not the world they live in. You understand? And also they suffer within. I don't hate a racist, but I can imagine it's a burden to carry that around with you your whole life. I don't have it. I'm liberated, I'm free. And so you have to help give them a chance to be free by showing them how it is to be free, you know, in your own actions toward them. So I'll tell that person who asked the question, the next time you see somebody of the minority or disadvantaged background, you know, if the person is a male in an environment where it's all male and a woman shows up, treat them like you would yourself. Treat them like you would the sister or the mother that you love. And it's easy to do. It's not rocket science. It's not nuclear chemistry. And over time, that person will transform others because they become transformed. And that's the chain reaction we need. The world is not going to be this way, but we have to be the agents of the change that we seek.
Beautiful, beautiful and inspiring as well. Last question. I think we will probably have more, but I would read the last one now. In relation to what you said, modeling for others, do you believe, and the question is coming from Andrea, do you believe that we need to have more cultural diversity courses included into the medical curriculum?
Yes, and a lot of medical schools are now doing that. It's very important. And I say it's extremely important. It's important for all society. It's important for elementary schools, middle schools, secondary schools, high schools, colleges, because you never assume that somebody, because we're in college, they're highly intelligent, and some of the perpetrators of race are highly educated people. They're not bad people. It's just what they learned. So I understand that carbon dioxide is CO2 and water is H2O. I learned that. You know what I mean? Mm-hmm. Now, if I learn water is H2P, I'll continue to think it's H2P. I have to unlearn that. That's, you know, the right way is H2O. So yes, I think, you know, we can continue to do that, and eventually, we will be able to attain some change in society.
Marie-Louise?
I just
last question.
No, I don't have any question right now. I was just really surprised about everything that you said before answering this last question about diversity courses, because you have such a unique perspective, especially this idea that we don't have to confront it, we have to act as models. So this is something very different from a lot of things that we hear around us, and very different from a lot of things that people are doing around.
Right. You know, the educational aspect is important because the so-called white people and the so-called Black people, you can tell, this race is just a human construct, okay? And so I say it just in the context of, you know, phenotypes that we can differentiate who's the victim and who's the perpetrator in general. And those who are disadvantaged, who are discriminated against when it comes to race, or discriminated against when it comes to gender, to overcome that, I think you don't want to create, you don't want to victimize others. One of the things I tell some Black folks when I talk to them is that there's some white resistance, because white people, when you start feeling like you're, you know, the guilt syndrome, like you're guilty. No, you have to create understanding that this is how I feel and it's not good. But you can't make the other person feel guilty that they perpetrated that, or maybe the guilt of their ancestors. Because you are from Romania, you didn't grow up here, but you are white in many people's eyes, and therefore you are bad. because you're part of the perpetrator. But they don't know how beautiful and clean and loving your heart is. You understand? And so we can't make generalizations. So it's better to engage, you know, than to threaten, than to make somebody to feel guilty. So a lot of the diversity courses, I always say, they have to be focused and centered around engagement, creating understanding, fostering understanding, because people are smart, people care, people really fundamentally are good. If they learn that, they can integrate it in their own lives and transform themselves better, you know? But if you start talking of, and that's why one of the things I'm not much of a proponent is making people feel guilty, like, you know, you are privileged, you are this. Heck, I was poor. I lived in ghetto. If you read in my book, I lived in a house with a bunch of rats and cockroaches everywhere. I mean, but the neighborhood was wonderful. They were good people. It was just a poor neighborhood. You understand? I don't want to live there now. I wanted to evolve economically, just like I wanted to evolve cognitively, and I want to evolve emotionally. You know what I mean? But if I evolve solo, it doesn't really give meaning to my life. What enriches my life is collective evolution. You know what I mean? And so that's why I engage others in my own behavior, so that maybe they can transform themselves, or we can work collectively to attain that. Many people hear about diversity. You know, I have not been involved in this a lot, but a few that I've heard, it comes across a little bit too confrontational to me. And I know what undergirds that. Some of this may be experiential anger. You know what I mean? It may not be targeted at the recipient or the audience, but that anger comes out, and that's wrong. It really should be, this is what we go through. This is our history. Maybe you didn't know. And then now you can understand our suffering. And how can we collectively deal with that without making assumptions that your heart, you know, is corporate as far as being a perpetrator.
Thank you so much. This is not, I called you a special guest for our event. I'm going to call you a special treat for the heart now. This is really something that I'm going to let it sink in and reflect on what you said. And I feel more motivated now to spread that good that you are talking about and to cultivate it more in myself and others. So thank you so much. Thank you, Marie-Louise. Thank you, Archer, and thank you, Arizona American Romanian Cultural Collaborative for making this happen. I think it was absolutely wonderful. We would love to have you come back whenever you want and can. It would be another special treat because you have so much to offer, and this topic is so important in our lives.
We're all together in this fabric, you know.
I also want to thank you, Dr. Zama, and I have to say that although I am here, the person who brought Dr. Zama to us is actually Julie Paulus from Arizona ARC. So that's why I really wanted to say this. And Dr. Zama, thank you for all the perspectives that you offered to us and the stories, and I'm really hoping that people are going to know much more and understand more, because you said this is your desire, right, for people to understand more and better.
Absolutely.
Yeah, exactly. And yeah, thank you, Julie. I mentioned ARC in general, but in particular to her for making this happen. It's really, I mean, it's, as I said, for me, it's like really heartfelt, and I'm definitely going to take this to another level. For those who have been with us today and those who are going to listen to you later, because this video is going to be available on our pages. Feel free to ask more questions. We will make sure that you'll have them and hopefully get some answers for them. Feel free to make comments and also share it, because we want people to hear and we want people to connect and to understand that we are all in this together. Thank you again, and have a beautiful evening.
Thank you. You too. God bless you.